Thanks very much, Camilla. Good morning, good afternoon, people. It's still very early here on the West Coast, but it's a very exciting set of data that we're discussing. So a pleasure to be with everyone. So I've been asked to give my clinical perspective. I'm a pulmonologist. You're going to hear from Shervin, who's a rheumatologist. And I think this data will impact the clinical practice for both of us. I thought I would just start by reminding everyone why the conditions that we're talking about are so important. Here I have some pictures of normal and fibrotic lung, both the whole lung and then a microscopic picture. So on the left, the far left, we have normal looking lung. And beside that, to its right, we have fibrotic lung. And this just illustrates very nicely what the disease does to the lungs. It shrinks them and completely destroys them. On the right-hand side, you can see those little cystic areas, which are the so-called honeycomb cysts that you will hear doctors talking about. And what those really represent is dense areas of scarring of the lungs. And then on the far right-hand side, we have pictures of the healthy lung at the top, where you can see the beautiful lace-like alveolar architecture of the lung. And the reason the lung looks like this is because it's an organ of gas exchange. It's designed to absorb oxygen from the air around us, and it's designed to get rid of carbon dioxide that is generated by the body through metabolism. And so those little alveolar spaces have very thin walls to allow the gases to move in both directions. Directly below that is a picture of fibrotic lung, and you can see all that pink stuff is fibrosis and scar tissue. And below it, the lung has become grossly abnormal with these big cysts that are filled with mucus-like material. And just looking at that, to me, it looks obvious why the lung no longer works in our patients with pulmonary fibrosis. Once the lung becomes scarred, it's no longer capable of gas exchange. And that's why our patients ultimately die from respiratory failure, often despite being given very high flows of oxygen as treatment. And so any of you that have spent any time listening to conferences or talks about interstitial lung disease will realize that we have tried to make it as complicated as possible. This diagram is taken from the guidelines of the American Thoracic Society and the European Respiratory Society, and it shows how we classify different forms of interstitial lung diseases. And already we have a problem because we're using lots of different terms, but interstitial lung diseases are any diseases that affect the wall of the alveolus, whether they cause inflammation or fibrosis. The majority of these conditions will cause fibrosis. We have this way of classifying them that is based on the histological appearance. But one of the challenges in clinical practice is that there's a lot of overlap between these groups. And so if you go to a clinical meeting on interstitial lung disease or pulmonary fibrosis, you will hear a lot of disagreement between even experts on the diagnosis of interstitial lung disease. And really, that was part of what led originally to the INBUILD trial, which was the trial of nintedanib in patients with progressive pulmonary fibrosis. It was the realization that the common theme that linked together all of these conditions was actually the pulmonary fibrosis. And ultimately, it's the pulmonary fibrosis that causes the patient's symptoms. It's what causes the breathlessness. And as it gets worse, it's what causes the respiratory failure and the need for oxygen. And so at the time the INBUILD trial was developed, really we were coming to this view that perhaps it was more important to focus on the fibrosis rather than worry about all of these distinct individual diagnoses in so much detail. And what this Venn diagram is trying to illustrate is just the fact that when it comes to pulmonary fibrosis, a lot of these diseases overlap. So not all patients with autoimmune related ILD will develop pulmonary fibrosis, but a significant proportion of them will. And the same is true for the other diagnostic categories that you see around the edges. And the reality is, once this progressive pulmonary fibrosis develops, the patient's clinical course becomes indistinguishable from that of idiopathic pulmonary fibrosis, which is to say that these patients have a poor prognosis, and we can expect that they will ultimately die from respiratory failure. And just to illustrate this, I've got a couple of patient CT scans here. On the left, we've got a patient with rheumatoid arthritis. On the right, a patient with systemic sclerosis. And if I just advance the slide, you'll see the rheumatoid arthritis patient. This scan is the same patient about 6 years later. And you can see it's gone from a sort of hazy gray appearance to now these little bubble areas, which are the fibrotic regions of scarring that map to that picture I showed you of the human lung. And so this patient has, over a period of a few years, developed pulmonary fibrosis that is in the process of getting gradually worse. On the right, we have a patient with scleroderma. Again, we're looking at these subtle gray areas in the lung, are evidence of early fibrosis. And if I just fast forward, this is the same patient 4 years later. And again, you can see that the gray areas have increased in extent. And within these, we can now see regions of established fibrosis. So again, these are diseases that historically we tended not to think so much about the pulmonary fibrosis, but now that we have treatment options, it has become something that we tend to focus on as being a very important part of the disease. And just to illustrate the point about the importance of progressive pulmonary fibrosis, this was a nice study published by the group out of Michigan a couple of years ago in the American Journal of Respiratory Critical Care Medicine. What they did was look at almost 2,000 patients that presented to various clinical centers across the US. On the left-hand side, they looked at their outcome based on diagnosis at first presentation. So this is when the patient first goes to see the doctor and gets a diagnosis. What it tells us is that the diagnosis is important. So this red line is patients with idiopathic pulmonary fibrosis. These patients have the worst outcome and survival. And then the patients with connective tissue disease, such as rheumatoid arthritis or scleroderma, have the best outcome. And in the middle, we have the other groups of diseases that appeared on that classification diagram. But if we then fast forward 12 months later, and we redefine these patients based on whether their disease has been stable or whether it has been progressive, which is to say they've either had worsening symptoms, worsening lung function, or worsening CT appearances, what we suddenly see is that patients who have evidence of disease progression all have an outcome that is indistinguishable from idiopathic pulmonary fibrosis. So the diagnosis is important to start with, but once we know that patient has developed progressive pulmonary fibrosis, then it is the pulmonary fibrosis that dictates their long-term outcome, which, as this slide shows, is poor. And then, as everyone knows, we've had the availability of nintedanib and pirfenidone as treatments for IPF since 2014, and we've had the availability of nintedanib as a treatment for progressive pulmonary fibrosis since 2019. And I probably don't need to tell a group of people who go out and interface with doctors and try and get them to prescribe nintedanib. But one of the real challenges that we've had with nintedanib is its side effect profile. And that has really limited its uptake in community pulmonology practices in the US. And it has also led to a large discontinuation rate. And that's not just true of nintedanib, it's also true of pirfenidone. And so we see this data that was published 2 or 3 years ago in the Annals of the American Thoracic Society, essentially showing that when we look at IPF, so a deadly disease with an average survival of 3 years, in the US, only about a quarter of patients with IPF are actually being treated with an antifibrotic drug. And I think that failure of uptake is really driven by the side effect profiles of these of the drugs we have available. And it's fair to say that a lot of my time and a lot of my nurses' time in my clinical practice is spent trying to manage side effects, giving patients advice on how we can minimize diarrhea. And it really takes up a lot of time for my staff. And a lot of patients find it a very disabling side effect. And there are patients who have to take out a spare pair of trousers whenever they leave the house for fear that they might soil themselves unexpectedly because of nintedanib. And so that brings us to the data that we've heard presented so nicely this afternoon. Donnie showed this slide. This is the efficacy outcome for nerandomilast in fibronear-ILD. And to me, this is a super exciting result. Since the development of nintedanib pirfenidone over 10 years ago, we've struggled to find new drugs that might replace them. And so to see what is very clearly a positive result in terms of slowing of FVC decline is truly exciting. Not only that, we are, as you heard, seeing a survival signal, particularly with the higher dose. So that sort of backs up the presumption that if you can slow disease decline, you will improve patient survival. And for the first time, we're actually seeing that play out in the clinical trial. So that's super exciting. And then you've been talked through the safety data. And although we have this big yellow box at the bottom that says diarrhea was the most frequent adverse event associated with nerandomilast, one has to put this in context. If you think back to the INBUILD trials and INPULSIS trials in IPF and progressive pulmonary fibrosis with nintedanib, we were seeing diarrhea rates of between 60 to 70% in the active treatment group. In reality, here we're only seeing about a 5% increase over placebo in the lower dose group and a sort of 10 to 12% increase over placebo in the nerandomilast 18 milligram group. And there were relatively few discontinuations for this side effect. So I think the take-home message from the adverse event profile seen in the clinical trials is that this is a drug that is much better tolerated than either nintedanib or pirfenidone. So not only are we seeing efficacy as essentially monotherapy, we're seeing efficacy of nerandomilast in combination with nintedanib, and we are seeing a tolerability profile that is much better than existing treatments. And so from my clinical perspective, that represents a real step change in our treatment options for patients with fibrotic lung disease of whatever etiology. This is a slide I've used for a while now in talks that I give at conferences, but it outlines our treatment options for these different diseases. And now with nerandomilast, when it comes to thinking about the use of antifibrotic therapy, not only do we have a third option to choose from in newly diagnosed patients, we also now have the possibility of combination treatment. And that really hasn't been a possibility before now. We just couldn't combine pirfenidone and nintedanib because patients couldn't tolerate them. But now we have the opportunity, hopefully, once the drug is approved, to think about combining treatment with nintedanib and nerandomilast as a way of really trying to prevent progression of pulmonary fibrosis in our patients. And as I've emphasized already, this really is a deadly disease, and I see so many patients die from it. And so to have a new option that really looks like it's an improvement on our old options is a very exciting place to be. So yeah, thank you very much for giving me the opportunity to present, and obviously congratulations to the BI team on getting us to this point, and I look forward to questions in a while.